All right, so it is 1:30 and we want to be respectful of everyone's time, so we'll go ahead and get started. I'm Callie Rockwell. I work for Burrows Consulting with Elizabeth Burrows, and we would like to welcome you to the Mobile Clinics 101 webinar. We were so excited when Mission Mobile Medical agreed to do this webinar and like come alongside us in it. And we just hope that everybody who is on this today has an opportunity to just learn what it is they need to from this, as well as ask some questions that might be lingering or get the answers to them. And with that, I'll turn it over to Laura and Maria for their introductions.
Sounds good. Hi, everybody. I'm Laura Naderbrocht, and I am with Mission Mobile Medical. I'm the Senior Relationship Manager here. And I think we have our slides in the wrong order, but that's okay. I am here with Maria, and we were so happy and honored actually to be able to work with Burrows on this, because we feel like this information just needs to get out there so we can expand healthcare services. So I've been in the specialty vehicle mobile healthcare for about 7.5. Well, I was 7.5 years, so now a total of 10 years. And I've been with Mission Mobile Medical 3 of those years. And super excited to be here because I'm a teacher at heart, and I understand and know how important education and training is, especially in the mobile healthcare world. And I'm really excited to be able to be a part of this. And I'll go ahead and let Maria do her introductions, and then we'll jump right in. Oh, you're on mute.
Sorry, typical thing, you're muted. So my name is Maria, and I came to Mission Mobile Medical last year, and I came from the University of Miami, being the director of community health, running school-based clinics, as well as expansion through mobile clinics, providing primary care, vaccination services, social work, mental health, you name it. So I found a passion for mobile healthcare and the solutions that there are that they bring. And so right now I am the director of mobile healthcare solutions at Mission Mobile Medical, and working at a national level to help programs and expand services, as well as community health centers, wherever it is that people are thinking of using mobile healthcare to expand services. So
very good. And so just really quick, we have this schedule just because we actually do a lot of and conduct a lot of trainings. And so this just happens to be one of them, and the one that we kind of felt like, and Burrows Consulting felt like would be the most valuable to everybody to get started with. So we'll go ahead and go to the next slide. So we're gonna kind of start with the types of mobile clinics, the size considerations, things to consider on when you're designing a mobile clinic, some of the things that you need to think about. And then we're going to jump into having Maria cover the technology and connectivity, and then the steps for building a mobile clinic program. So these are quick little depictions of some of the differences between the vehicles. So at the very top, they'll call a van, so a van can be a lot of different things to a lot of different people, but technically a van is just that, it's just a van. So a van tends to be a smaller clinic. Very often you can fit a small exam room in there, possibly a bathroom, a sink. So you actually can fit a lot in those small spaces, but they tend to be better used for health screenings, a little less full primary care, but there are a lot of things that you can do with a van. So, but they do tend to just have, one provider, one patient kind of situation, because there just isn't a lot of room. The next size down, or the next size up actually, would be the small class A, and it's a little bit larger than a van, and you can get more space, more people, but it maneuvers more like a van because of the length, just a little bit longer, a little bit wider, a little bit taller. And you can get a full exam room in there, a bathroom, waiting area, intake space. And so that tends to give you a little bit more space, but kind of the same types of services that you can do on a van. And then you can go up to the medium class C size where you can do single exam. And I think on the next one, you can even see that they do dual exams on those as well. And then the large class A. So you can kind of see the difference just by looking at those 4 depictions, that there's a difference between the class A, which looks a little bit, more of an RV, looks more like a coach. You can sometimes hear people call them coaches. And then the medium class C, the class C is where you see the cab is separate from the body. It's not all one big body like the other ones. So if you have somebody that talks about a class C, or that they want something that looks more like it has a truck in the front, and then the body in the back. So it's just kind of one of those, start talking different technical terms. All of these can be anywhere from about 24 feet long all the way to about 33 feet long. And then you can see here, I wanted to show a real quick description of the smaller class A, where you have entrance in the front, and you can see the little pop out gives you a little extra space for the waiting and bench storage area, the bathroom, workstations, a lot of different places. Whoever you're going to build your clinic, they're all going to have different options on things that you can do. This just happens to be a depiction of some of the things that we do. There'll be options where you can put a sink somewhere, and you just have to work with your builder to decide what your patient flow is going to be. And that's something you have to really think about. How many staff members do you think you're going to need? What is your patient flow going to be? How many patients do you want to serve? So all of those things are going to be considered when you think about the size of vehicle that you're going to be designing your program around. So the next one, these tend to be a little bit bigger. So you can do 2 exam rooms on a class C. You can also go to a class A little bit larger, 33 foot to 38 feet. And you can get as large as 38 feet without going over the CDL requirement. That threshold is 26,000 GVWR. So once you get past that threshold, then you start getting into requiring a CDL. But everything that we build, and most builders will provide you with a vehicle that does not require a CDL. And I say that with the caveat that even though it doesn't require a CDL, it always requires training and practice. And that's something that you will see coming from us, especially for very training-centered organization as we are. That's why Burrows Consulting does what they do. They want to educate people. They want everybody to know the best way and best practices. And so we make sure that we provide all of that training for all of these mobile clinics. No matter who built your clinic, we will always be able to provide training for you. So this is an example of this is our largest 38-foot dual exam. Again, most builders, whoever you're working with, will be able to provide a vehicle of this size. This is the primary care. You can see where there is the entrance in the center. To the right is the larger exam room, and to the rear is the smaller exam room. Lot of different options to go there. You can provide a lot of different patient flow here, but this is probably the most popular request when it comes to primary care and dental services. Next slide. And there's our dental. So as you can see, there's plenty of space in the front, plenty of space in the rear, and you're able to get your dental assistant, the dentist, possibly medical assistant somewhere in the center to be able to check people in. So patient flow and dental actually is really been growing and expanding, especially in the health center world, as more health centers are starting to provide dental services as well. But again, this is the largest size is 38 feet. Cab style is kind of coach style. It's a class A RV, and you're able to drive this without a CDL, but with training. Next slide. So some of the things that are going to influence the size of clinic that you're going to decide on, and there's a lot of considerations, not just the services that you want to provide and the population that you're going to provide, but also what is your environment? Are you urban or are you rural? And sometimes in an urban setting, the larger vehicles can be a little more tricky, and they may create a little bit more planning. So think about the size of your parking and the storage. So where is the vehicle going to be parked when it's not in use? Do you have places? Do you have to have covered parking? Are there regulations in your area about where you can park it? Do you have access to power? So all of those things are going to be something that you're going to have to work through in part of your planning stage. The services that you want to provide. So, when you're, say you start as primary care, but you want to maybe add something else and you're changing your scope, then you have to make sure that you plan for the future. So think of all the different things that you're going to want to do, because you can have those encounters that can change, and you may want to be able to use it for multiple purposes. Also, how many patients do you want to serve? So if you think about the patients that you're serving, what is the throughput? How many people do you believe that you're going to need to serve every time you go out into your community to be able to get the return within your community, to be able to help improve those outcomes? So think about how many patients that you want, the roadway limitations in your area. Are there low bridges? Are there places that you know that you're just not going to be able to get in and out of? So all of those things take planning when you think about the environment of where you're going to be. Non-CDL requirements, there's a lot of non-CDL options out there. So you don't have to feel limited at all about the CDL requirement. I know that there's a lot of folks that can be an intimidation factor for them, but just know that whoever you're working with, if it's with us or anybody else, that all builders are going to be able to provide you with options that are non-CDL. And then looking at the details and understanding how the floor plan changes can affect your space. So when you're planning and you're looking at your floor plan, make sure that you're talking to somebody who's knowledgeable about what can and cannot be done, because the minute you start to add certain things, it can take away from other areas that maybe you didn't realize that when you add something that is going to take another 8 inches away from the space that you have to work with. So make sure that when you make any changes, or if you make any changes and you're working through the design with your builder, that you are talking about some of those space limitations. So going through the floor plan with your builder is really important, and understanding what those schematics are telling you, because sometimes it just looks like a picture. It can seem very overwhelming. So being able to really go through those schematics is really important. And also think about, are you asking for too much? Remember that you're on a mobile platform. It does need to be an extension of the brick and mortar, but at the same time, understand that you are going to be working on a mobile space, and you're going to have to learn how to work a little bit differently. So coming up with a plan and working differently is going to be important as well. Next slide. So here's just some interior photos, representative interior photos of some of the space that you could be working with. Also think about if you have a mobile clinic that doesn't have the slide outs, you're going to be working in a little bit tighter space. Having those slide outs is very beneficial when you're talking about being able to maybe have the whole family in one room. If you have the mom and the dad and the children, that you'll have plenty of space. But sometimes you're not going to have that space, and you have to, find ways to work around that. Do you need to set up some tents outside for people to wait? How are you going to check people in? Will they be checking in outside of the vehicle or inside of the vehicle? A lot of it's going to be weather dependent as well. So thinking about your climate and preparing for all of those things. Next slide. All right, so I'm going to go ahead and let Maria take it from here. She actually is more of the expert. I'm more on the technical side when it comes to the vehicles. So if you have questions about those, feel free to ask me. But Maria is the one who's been the boots on the ground, so I'm going to let her take it from here.
Yeah, thank you, Laura. And if you have questions also as we go through the presentation, you can go ahead and put them in the chat, and then we'll keep answering as we go or at the end. So some of the most common services provided in mobile health clinics, there's a lot. You can think of it. So there's about 2,000 mobile clinics today in the US, and they're parking at the doorstep of the patients. And this is what they're addressing. So increased access to preventative care, health screenings, primary care, pediatrics, management of chronic diseases. School health-based services are being expanded through mobile clinics. That's a big new thing. Addiction services, vaccinations, dental and vision services, telehealth, women's health, cancer prevention, maternal and infant health, community outreach, mental health, STI treatment, specialty care, disaster relief, imaging services. And I put ... because there's many more. Probably somebody can think of something else, but some of the new ones that we've gotten is medication management and also infusion. Now it's being done in mobile clinics. So if you can think of something that you can do in a brick and mortar that doesn't have a lot of, doesn't require a lot of space, but more than anything, just outreach, that's the right environment for it. So let's talk about connectivity for mobile health clinics. First off, why would we use connectivity? Number one is to connect with the organization with a hub, right? Usually there's a hub, a clinic where this mobile clinic is connected to. So it's a satellite of a main clinic. And so internet access allows it to connect with that hub. So you need it because of that. You need it for electronic health records. Everybody's doing electronic health records in mobile clinics. Up to some years ago, we were still doing paper. So then it became where mobile clinics were able to connect through internet to the EHRs and directly, right? Not through even a channel, but just directly into them. And security and maintenance. So having internet connection allows for the mobile clinic itself being able to be monitored and troubleshooting through GPS systems, so which allows to better use of your mobile clinic and not it be. And I think my favorite one is telehealth. Why? Because this is actually in one of the mobile clinics, how providers are using telehealth to be creative. Where the provider doesn't have to be in the mobile clinic, but then there is either nursing staff or community outreach person that's with a patient, communicating through live video teleconference. And of course, there's e-consultation, provider support and training. So there's some education being done, mental health, health monitoring, chronic care management. That's a big piece of telehealth. Connecting with community health workers. And I should have added there, school-based models now are using telehealth to expand services to some schools that don't have the ability to do that, but they still can have the mobile clinic go there, but the provider is not available. So let's talk about what people have a hard time thinking. What if there's no cellular service, right? So you have two options really on connectivity. You can go with a cellular or satellite. So the difference is usually the cellular goes from the vehicle to a tower, and the tower communicates with space. Now on satellite, it skips the tower, right? So it goes directly into the space. So you're going to be able to get better service in remote areas with satellite, but it's not needed. It depends where you are going. So this is a screenshot from the FCC National Broadband Map, where you put, and you see in my example, I just put a county in Illinois, and it brings exactly that county. And if you notice on the legend of it, the white areas is where there's less connectivity. And then you go into the lighter purple and greater purple. So you can go ahead and plan for it. Why do you need to plan for this? Is because, well, this is, sorry, it just popped out. The picture of how the equipment looks. It's not like a big deal. Just a small piece of equipment that's that we put in the mobile clinics already for you guys to use. But then there's always the question is, why do we have to map it? It's because mobile clinics usually go with 2 or 3 providers. So we don't just say, oh, we're going to go with Verizon, just like your phone, right? Imagine if you can have on your phone the ability to change from one provider to the other one, depending on how much, what the communication is like for each provider. So for example, in the same area that I just mapped, the other one, it looks like Verizon is the percentage with the highest coverage. Then it goes AT&T and then T-Mobile. So in this mobile clinic, we could have Verizon, AT&T, and T-Mobile, where when one fails, the other one picks up, and so forth. So that's how we do it. But yeah. Okay, so that's in regards to communication. Now let's talk about how do we build the mobile clinic inside. It's easy to bring the mobile clinic to places in a way, but it's hard to figure out what goes inside. And really what goes inside is what's going to tell us how impactful a program is. So number one, the step number one, we take it as planning. We need to know the area logistics. We need to know an outreach plan. And this we call theory of action, which means you're going to have to come up with an outreach plan according to the area you want to cover. Then we look at the provision of services. What are you going to do service in a mobile unit? Never think, oh, I'm only going to start with vaccines, and so I'm only going to have one exam room, because you're going to want to expand really quick in a mobile environment. So always think of the max that you can do, even though you want to start, maybe you want to start slower, but you still want to think of what is the max of what I would like to serve the community. After I do the logistics of the area, then I say, okay, we need some chronic care management in here. So we're going to start with asthma clinic, but then we're going to, increase or grow on the services. So always think of those. And then the outcomes and the data. What do you want to prove? What do you want to get out of this, right? Not only serving the community that is right now underrepresented in some way, but also what kind of data am I going to get there? And that we call effect theory, right? We're going to look at what's going to happen, how we're going to measure it, and then from there, we're going to look and see how to measure it and make different decisions, right? So we talked about the SMART framework for objectives, and those are like the ones that are measurable in time. Now, there is a theory that in mobile clinic programs, we don't want to be so time, we don't want to think, oh, only from January to May, I'm going to offer this, right? So be careful with doing those time constraints. It's more on how will I offer, how long will it take me to evaluate something and then change and pivot to something else. That's the other thing. Mobile clinic programs are easily to be pivoted into other types of services, other types of logistics to it. So it's very important that we look at what are we looking to measure, right? So patient satisfaction and experience, that's more qualitative measurements versus quantitative, which could be number of vaccines administered, number of visits, etc. So from there, then you have an evaluation plan. When will I look back at the data, at the outcomes, and see if I need to switch, right? A lot of programs you'll see, they'll go with, okay, I have to see 20 patients a day for it to be a program that's worth the time and the staff going out. And then if I don't see 20 visits per day in 3 months, and then a lot of them park it, right? A lot of programs park it and say, well, I'm not sure what to do. This is when you say that might not be the right side, might not be the right hours, right? So you have to always think of an evaluation plan and what will you do to make it better. And then a sustainability plan. How will this be sustainable for a period of time that I want to start, maybe pilot it, and then go back into how will it be for the next 1 year, the next 3 years, the next 5 years. All right, so you always want to think about how will it be sustainable and what better ways can I do? And define the timeline. And that's when I said more than months, you want to say, I want to pilot for 3 months, see what happens. Then it takes at least a year to become good at this and to know what it is. And that's just a year, because that we would consider the pilot in a way. So just give yourself some time, give the opportunity to the program to grow. And the timeline, you want to define when will you launch, what time of, is it a soft launch, and when will you evaluate? You want to create a calendar, a physical calendar, and will you be doing also special events? So, all right, so step 2 is productivity. So under productivity, we have a whole financial kind of framework to look at these things, and there's a science behind how will you plan this, and this is why we talk about productivity. So we're going to talk about how many days in the year will you serve the community. So once you figure out how many days you will serve, is it 5 days a week, 4 days a week, whatever it is. And then after you figure that out, is in a year, how many of those days I'm going to have to take away because of PTO, inactive days, paid holidays. And you calculate the amount for a year. You can see in the 12 months, how many days available will you have to serve. And all these yellow fields or cells are always fillable by your program. You have to calculate those, and then the 200, of course, would be the subtraction in between them. And then how many patients can you see? So you have to think how many hours a day will you be there? How many minutes does it take for the provider to see the patient, not for the whole total visit, but the provider, because that's going to be your higher cost. And how many visits per day per room, that's calculated. If it's a dual exam, it's a little bit more visits, even though you have one provider, being because the provider can jump from one room to the next without having to transition the other patient out, right? So I'm probably preaching to the choir if you're into clinics, and you know exactly how that would work. And then the efficiency, that we call the reality check, right? Like, will I get to have 3,200 annual visits at full capacity every day of the year on the first year? So let's say we say, nope, there's no way. So let's say I'm going to calculate 60% potential reality check for the first year, 75% for the second year, third year, 95%. And this is just an example to show you what you have to look at when you talk about productivity. And then again, we're looking at medical providers, estimating the provider visit length, program days, and then program number of visits. Capacity per year, which is the reality check. So those are the 5 main things that you should look at when you talk about how productive your program will be. And then the labor cost. So the labor cost is your highest cost, and this is why you have to put together what is your staff profile going to be. So best practices say for primary care unit, you would have one medical provider, which is usually a nurse practitioner or PA, and then you would have also a medical assistant, somebody assisting that provider, right? That's your minimal, and then from there you can multiply and do whatever calculations you need to do, but the staff profile, and of course the driver. Sorry, that's probably the most important one. And then, so you're looking at 4 things. You're looking at the roles of each staff member. You're looking at the annual wages. You're looking at FTEs, how much time they're going to spend in the actual program. And you're looking at the labor overhead. All right. So the roles, usually it's a provider, like I said, a medical assistant. If you need an extra nurse for certain services, you need another nurse. Community health worker, that's something that we recommend, and best practices is have someone, even if it is not one FTE, but it could be 0.5 FTEs, whatever it is, and then the operator, who's the driver. In many times we see the operator and the community health worker be one, so one person that runs both of those roles. Or it could also be that one of the nurses or medical assistant also runs a dual role. And then you look at the annual wages, you look at your, do some market salary research. There's no difference in between really in a mobile clinic wage than brick and mortar, no difference. And then define the amount of time that we would contribute to that program. So some of the clinics might go out 3 days a week and using a provider. So that is not a full FTE, of course. And then the other 2 days might just go out with a telehealth kind of picture, right? So it depends on how you want to mix it. And then the labor overhead, which general rule of thumb is about 20 to 25% of overhead expenses, depends on your organization. So again, look at the overhead, the role of the operator. So this is one where we put a lot of emphasis to, which is, are they going to play a double role, the operator of the clinic? But the most important thing is the operator does run the maintenance and the service of the clinic. They park the clinic, they clean the clinic, the whole thing. So this is the kind of person that you want to be trained to do all that work. And like Laura said, for example, organization like ours, we train the operators. So we bring them sort of specific training on just that. And then, this is just one of the pictures of an operator. We'll go to step 4, which are your expenses. So we talk about direct costs, and some of the direct costs that we see is the startup costs, medical supplies. So the startup costs can be anything like internet startup costs or, equipment, some specific equipment that you need for the clinic. So anything that's just a one-time cost, medical supplies. We make up per visit calculation. So you saw how we said, oh, there's going to be 3,000 medical visits. And usually we calculate about $6 of medical supplies per visit. It's between $4 and $8 is what we've seen around the market in the US. And so we make a per visit calculation. We also have to look at certifications, IT, storage and fuel. How much is it going to cost us? So let's get an example of fuel so you have an idea. So fuel average is around $4 a gallon. Let's say you go 60 miles per day, 200 clinical days. So you multiply, and then you get an approximate cost. Fixed expenses, you have to think about auto insurance, marketing and outreach, a service contract for the mobile unit, and contingency budget for anything else that we need. And of course, program coordination and program planning. How much time is a coordinator, or I'd love to call them a champion, right? How much time does a champion of the program is going to spend in planning, creating schedules, going to events, figuring it all out. So you also want to program that. Then step number 5 is something we call the payer mix. So we're going to look at different ways of how do we get paid for the services, right? So one of them is patient revenue, which is critical to sustainability. And you're going to see another kind of spreadsheet that we have as part of our financial model. And then braided funding. Where is your funding coming from, and how does it go one with the other, and how does it support the clinic? So our service income comes from four ways, right? Just best practices say. Reimbursement, which is usually a blended rate. So we figure out, okay, how much per visit can you get for, how much do you usually get per visit in the state that you are, in the place where you are, the type of organization that you are, and you calculate an average, right? So you go with the market and you calculate an average. Then if there's any managed care payments, those are usually specific to the organization, but if you have those, how much of those do you foresee in a year? And then you have your forecasted number of visits. So all you're going to have to do is multiply those by that, and the percent of allowance for uninsured visits, right? And how much do you get for those uninsured visits? So once you have those set up and you have percentages of each of those, then you can calculate around how much revenue will you bring into the program by patient care. Then we look at something called, the return on investment, the ROI, but we look at different ways. So we look at external funding. We look at organizations that champion and address specific issues. So you want to go to your community, to anybody that champions, let's say you're looking at expansion of school health services. So you're going to look at your school district. And then this is kind of part of our financial spreadsheet. And this is, we believe that whoever is receiving the return should also be putting in the I or the investment, right? So if there's a local philanthropy and look how it's split, right? It says the organization, the support, and then the results received. That's what you want to present to the organization. A lot of the organizations will say, well, how much are you getting from philanthropy? And how much are you getting? So this is a good way to present to them, look, you're just putting $10,000 because we have a community foundation grant that puts another 10. And we're looking at the school district support that's putting another 10. And then giving them the results, the outcomes, the impact that you're going to see is important, right? What are they going to get? So for example, just give one school district, right? You can reduce absenteeism. You can have higher graduation rates. You can have less chronic conditions. You know, any data that you can start thinking of that could be improved by providing services through mobile clinics, and you want to show that. So this is called the patronage model, which everybody that's involved could give a part of it. And then, of course, then you have your total. So let's say from there, you can bring from the operating income from patients, you can bring 600,000, about 600,000, and then 125,000 from donations, and you have a potential income that you can work with. So this is important for the sustainability of mobile clinics. Okay, now step number 7, we call these strategies. So there's different approaches to getting a mobile clinic. So before, so I was working with mobile clinics before pandemic, during pandemic, and after pandemic. So before the pandemic, most likely most clinics, community health centers or clinics or organizations would have to look into how would I purchase a mobile clinic? How much does it cost? How will I get it funded? So that's approach number 1. You're always going to look at what you have for funding and what is it going to cost you. But again, you have to look at how much would it cost for the program itself, right? And then you have, during the pandemic, we saw a different kind of approach, which because we were thrown money, when I was at the University of Miami, we're thrown money like crazy, like go give vaccinations and go and do testing, whatever it is. And you can even lease a mobile clinic. So then that whole pattern of leasing mobile clinics came to picture. And then we became even more creative. Now we can lease mobile clinics even with staff, right? Because some of the agencies, organizations have a hard time getting this staff. So that's another approach that you can take towards building the program. And then number 3, which is one of my favorites, is partnership with other organizations. Share the revenue. Maybe it's 2 FQHCs partnering with each other. One will take it out 2 days a week, the other one will take it 3 days a week, and would revenue share. Or one will park at a YMCA, and the YMCA has specific days in which they can share some of the revenue, and you can share some of the revenue for the program. So these are just some of the creative ways we're doing this, just to help organizations kind of think that it's not the only option. It's not only to buy one, because you might not have, or you might have the money for that, but you don't have the money to operate it. So then approach number 2 would be better, right? Use the money that you have to operate it, and then lease it by a flat fee in a month, something like that. So it's like kind of a financial kind of way. And so if you want to increase access, we say always best practices is step number 1, forget everything you heard about how it worked in the past. because like I said before the pandemic, it was different to have a mobile clinic program. And so, and then that is it for the presentation. So I'm not sure if there are any questions, or if anybody wants to jump in and ask any questions, we're here to help you answer them. So.
Yeah, and thank you so much, the Mission Mobile Medical Team. And I just wanted to say, this is the first time that mobile clinics are being allowed on a new Access Point grant application for FQHCs that we regularly work with and write about. So, really excited about that. As many people know, I keep a mobile clinic in my office, and I did mobile clinics before they were cool. Back in about 2012, 13, and 14. So I haven't met a mobile clinic I don't like. And again, we're glad to reach out, help you get funding, connect you with Mission Mobile Medical, because again, they really do think about all the things. And I think if I would have had this presentation when I started my mobile clinic, it would have been amazing. I wish I would have had this. A couple of things we've had people ask: can you do SUD services on mobile clinics, and what is a successful approach to that? The NAPs are requiring SUD services. We've had a lot of questions about that. Could one of you speak on that?
Yeah, I mean, actually, any of us could. I think we even have one of our teammates on who could probably even do even better. But yes, absolutely, you can do SUD services. We have been building and providing those services. I think Washington is the one leading the way right now for mobile OTP and MAT. And we do work very closely with the DEA, with each state SOTA, with the regulations to make sure that the program is successful. So if you need more specifics around that, yeah, Jackie's on the line. If someone has specific questions about that, we can even have a completely separate conversation, or they can reach out to us. But we're expanding that, and we are very knowledgeable, and she is our expert in that field in addiction services.
Callie, feel free to interrupt me if you've had other questions come your way. But I did want to talk about too, one of the new requirements with the NAP grant is having something 40 hours a week. Can you talk about some successful methods you've had for how to use mobile clinics 40 hours a week? We have a lot of clients using them, say 16 hours a week, 20 hours a week, and getting that up to 40 might be a challenge. Could you comment on that?
I think we were thinking the same thing, right, Maria? There might be a challenge.
Yeah, well, yes, it is a challenge, but at the same time, I know that's in the NAP grants, right? Is that why probably they're asking? Yeah. So one of the things that we've, that I personally believe is seeing a mobile clinic as a satellite clinic. It is not just for an event. It is not just to take out twice a week. It is really, you should have a plan. And this is why we go through some of the program planning, because there's creative ways that you can do that. I touched a little bit on telehealth, right? If you can have it 2 days a week out with just a nursing staff and do some telehealth. It also, you can provide just immunizations at some point and do not have the provider, which could be the hardest thing, right? Or you could have 2 providers rotating through the mobile clinics. But there's certainly a way to do it. And it does include from the outreach, from when you get there and you're doing outreach to the time that you're seeing patients. And very easily you can go 8 hours a day. There were times when we had to say, gosh, we gotta go home because the 8 hours were already there. And so yeah. I don't know, Jackie, if you wanted to say something. I know your hand is up. So
yes, and I apologize that I'm not on camera. I was driving when this started. So when adding the SUD services, which is a requirement of the NAP grant, that's a perfect opportunity to add to the hours Maria was just mentioning. So offering counseling services for SUD, harm reduction, outreach and education, MAT services. To dispense methadone on the clinic, you have to be a licensed OTP, which we can get into that, all the specifics around that at another time. But taking the SUD component and adding that to all the great ideas that Maria just shared will easily get you to 40 hours. And that you can split your staff there, right? So your SUD staff and your medical staff is likely comprised of different individuals throughout your organization, so that folks that only have a certain amount of hours to dedicate for primary care, preventative care on the mobile clinic, then your SUD staff can step in.
Correct.
Another question that has came in, and I've actually been asked this a lot too, as I've talked with different people wanting to go after the NAP grants, which is the zoning requirements. And I know you guys touched on that, and each case would be different. I know in my experience with mobile clinics, there hasn't been zoning issues. We've been able to pull up pretty much wherever, but that's been something with people trying to pull off a clinic quickly. Could you talk about if you've had zoning issues and, you know, how you address that?
Yeah, so same way like what you just said. So most of the times that this issues come up is because you're right, you're just taking the mobile clinic and parking it. And that is not the right way, right? Best practices, you have to contact the place where you're going to go and find out if there's any zoning issues. They'll let you know, but most of the places we parked in 17 different sites types in Miami-Dade, where zoning is huge, and we had never a problem. I think the only place where we had some type of MOU of some type would be with schools, and that was easy. That was done through the school district and done. Like, you know, I'm sure maybe for OTPs or something like that could be a little bit more trickier, but it's usually just done, you know, if you do your homework of going into sites and seeing, they'll answer you those questions very well. Like, yeah.
Perfect. Callie, have you had any questions come into you? I think that wraps up my questions.
Yeah, we had some initial ones from the registration. The first one was, are there just any common mistakes to avoid when setting up a mobile clinic?
Yeah, so I would say we could probably all talk about common mistakes, right? Because we've all done them. So, you know, on my experience, the most common mistake is number one, if you don't plan something, right? If you just throw it out there, buy a mobile clinic and just think that people are going to come, that's a common mistake. No, you have to do your outreach homework, your marketing homework. You have to plan everything about it, right? That's why we put so much emphasis into planning for programs, because that's a big part of it. And I would say that the number two is not giving it the time, right? It's not going to work in 3 months. And if you think that's going to be like, oh, well, we're not going to do it. And that's why we see mobile clinics parked, because people are not taking the time and to be able to realize that you can pivot really quickly. It's mobile. You can pivot your plan right away. You can say, this is not working. Let's go back to a different site. Let's see, let's extend our hours. Let's start later. Let's start sooner. It doesn't matter, right? And or also think that it's only for special events. I think those are probably the most common mistakes, and not having a maintenance plan. That's actually important, because if you don't have a maintenance plan and you think because it's a new mobile unit, it's not going to break, forget it. It's not going to happen. You're always going to have trouble with the canopy, with the generator, with air conditioning. You know, things are going to break no matter what. So have a plan for maintenance and service as well. So
I have to jump in there, Maria. So I always tell stories. And one of my favorite stories is we did not have a maintenance plan, but we were going to serve 14 different schools. And one of the career and technical education components of those 14 schools, they needed to do work on semis and on motorhomes and things. So they actually proactively came to me and said, hey, could we use your clinic, your mobile clinic once a month, and that'll give us a chance to do all the maintenance, and we can teach our students at the schools that it's serving how to properly care for it. So I will tell you, I looked into an amazing free maintenance plan, and the people I wrote grants to get that funding, they loved that being written in, because as we were meeting with the schools, that was actually something that came up, because the students got to maintenance buses and they got to maintenance trucks and cars, but they didn't have kind of that other type of piece of equipment to maintenance and to service. So that was really exciting for us and a great partnership with the school. So again, always trying to think outside the box too for that community buy-in, because if a student goes home and tells their mom, hey, I got to maintenance this new fancy clinic and they've seen it and they love this, and they're like, oh, that's really cool. They're going to be more likely to utilize that in the community when you get more of that community buy-in. So
yeah, and that opens up for, like you said, think outside the box, think creatively. How can I get this done by using my community assets, right? Like, what do I have in my community that would help me take care of that? So definitely being creative, that's one of the ways. But yeah, for sure. Thank you, Elizabeth.
And they also had to outdoor clean it once a week. That was part of their duty. So we were really
Oh.
spoiled.
Yeah.
Wow, you really lucked out.
we lucked out, and I think that's why the bus lasted. So in fact, it's still going over 10 or 12 years later. So they're still, because of that good maintenance, and again, letting those students have that buy-in. Okay, Callie, do you have anything else?
Well, you kind of two birds, one stone. The next question was a maintenance, and you covered it. So
That's the thing about, we cover maintenance and other things too. I'm sure you guys are aware of that. And that is one of the things that we tell everybody is that these clinics will go for a long time, or they will go for 1 year. It's up to you, and you have to maintain all the things. You don't just have your engine, you have your generator. Well, guess what? Generator's an engine too. You have the seals around the windows, you have the seals around your air conditioner, you have the seals around lights. And if those seals aren't maintained, we have perfect examples in our shop right now where they weren't maintained and water damage gets in there. And now we're cleaning up and rebuilding floors because of the dry rot. And this is a vehicle that should have lasted so much longer than what it did, and it's only because they didn't maintain it, and they ignored warning signs. And so it's great to be able to help them, but it also would have been really great for it to never go out of service in the first place. And it's all about maintaining the vehicle. It's not just the engine, it's not just the oil, it's all the different components of your mobile clinic. And if you stay up on your maintenance and you have a good schedule and you have good partners in your neighborhood, you can keep these clinics on the road for so much longer.
And to that, I would add even the cleaning inside. So we were also creative, took it to one of the hospitals, and we said, if you clean it like a hospital room once a month, what can we do for you? And they said, if you can come and do pre-screenings in the beginning of the month to employees, we will exchange that service for the others. So we had it clean at a hospital, hospitalized, sanitized, the whole thing, and we did another service for them. So you just got to be creative in how you do things. Yeah.
All right. Well, thank you to the Mission Mobile Medical team. I'm excited for a site visit next month. I'm going to go see a lot of their facilities and see clinics being made. So the other side of it, again, if you're watching this on YouTube, we'll have our contact information, and feel free to reach out to Callie or myself or any of the Mission Mobile Medical team if you want further information about mobile clinics. Good luck in your grant writing for mobile clinics. And if there's any way that we can help at Burrows Consulting, please reach out. We would love to assist you with that. Thank you all for your time and have a great day.
Thank you, Elizabeth, for having me.
Bye, Elizabeth. Bye, Callie. Thank you.